partial and complete. Invasive mole. That means this mole formed from villi, and from its name, it is invasive. That means from endometrium invade the myometrium. The villi here penetrate inside the myometrium and become invasive mole. The third one, which is the malignant of trophoblastic cells, is a choriocarcinoma. And we will talk in the ovary about non-gestational choriocarcinoma. Here we will talk about gestational choriocarcinoma. The non-gestational choriocarcinoma that arise in the ovary, which arise from which cell? Which cell?
Trophoblast.
Germ cell. As you know, the germ cell tumors differentiate into embryonic structure, forming teratoma, extra-embryonic structure forming choriocarcinoma and yolk sac. And that choriocarcinoma, we call it non-gestational choriocarcinoma. Here, we will call this gestational choriocarcinoma. Other tumor is the placental site trophoblastic tumor. Placental site trophoblastic tumor. From its name, it arises from the placenta, at which where it arises at the site of the placenta. So that we call it placental site trophoblastic tumor. Arise from which cell? It arises from intermediate trophoblast. Intermediate trophoblast. Let us talk about the hydatiform one. And hydatiform one are important. Why it is important to recognize hydatiform one? Because they are associated with increased risk of persistent trophoblastic disease. It may transform from hydatiform mole to invasive mole. At this point, it will penetrate the myometrium, okay, and become invasive mole. All the others, malignant transformation is a choriocarcinoma. So that you have to know the hydatiform mole very well. You have to differentiate between the partial and complete, and always the complete mole has a propensity to develop choriocarcinoma. Okay, 2 to 2.5% in complete hydatiform mole may transform into choriocarcinoma. So that you have to know the hydatiform mole well, and you have to know which one of it, or each of them, partial or complete. Mole are characterized by histologically cystic swelling of the chorionic villi. You know that the placenta is formed from chorionic villi lined by cyclones and tissue trophoblast. Okay, with a variable size, Okay, here in this condition, hydatiform mole, when this villi become cystically dilated, okay, here we will call it hydatiform mole. And it's the same placenta, but undergo cystic swelling of the villi. So that transforms from normal placenta with a variable size villi to abnormal large cystic swelling of villi. Okay? Here at this point, we call it hydatiform mole. And the villi is lined by trophoblastic cells. Also, in hydatiform mole, there is proliferation of these trophoblastic cells. Okay. And two conditions will occur in the placenta. After that, we call it hydatiform mole. The first one, cystic swelling of the villi. The second one, trophoblastic proliferation. Okay? They are usually diagnosed during early pregnancy. Always 9 weeks. And second month. After second month, sorry. And third month by pelvic ultrasound or sonography. Okay?
دكتورة
Yes.
معليش الحين الهايداتيفورم مولز هذه cytological change ولا what؟
Here both gross and psychological. Grossly, we found that the villi become swelling. Okay? Cystically swelling. يعني when you see the placenta, normal placenta, you see it as a solid tissue. Here, when you see the hydatiform mole, you will see vesicles.
Okay.
Vesicles. Looks like vesicles. Yeah, yes, I will discuss this and I will mention this, inshallah. Here, before we talk about the difference between the partial and the complete, let us talk about the clinical presentation. Both of them are, the patient came with spontaneous abortion or bleeding. Spontaneous abortion or bleeding. A uterus usually larger than expected the date. Yani if it is 9-week uterus, it will become enlarged. But when carried hydatiform mole, it will be very large. Yani it is larger than expected date. Okay? The ultrasound shows diffuse villous enlargement. The villi become enlarged, cystically swelling. And a serum quantitative HCG elevated much higher than normal pregnancy of similar gestation. If we suppose that the pregnancy at 9 weeks, the HCG will become 1,000. If it transforms to hydatiform, it will be 3,000. That means the serum quantitative HCG much higher than normal pregnancy of similar gestation.
هذه الحالات تجي بس بالحامل.
Yes, this is a gestational trophoblast. This is from the start. I ask you about what's the name of this
Okay.
gestation. That means pregnancy.
ما كنت Okay.
The treatment of this hydatiform mole is uterine curettage to take off all of this abnormal placental tissue. Okay? Follow up. You have to follow this lady with HCG until they are due for 12 months. Okay? After curettage, I will do for them serially HCG until it becomes 0. Okay? The risk for developing choriocarcinoma is up to 2.5%, which is mostly associated with complete mole. Okay? In every 40 hydatiform mole, it will develop choriocarcinoma. In every 40 hydatiform mole, one of them will transform to choriocarcinoma. In normal pregnancy, every 150,000 will develop choriocarcinoma. That means, in the condition of hydatiform mole, the transformation to choriocarcinoma is near the normal pregnancy. Okay? Let us talk about the gross and histology of hydatiform mole. Grossly, there is cystic swelling of the chorionic villi and there is trophoblastic proliferation.
مول يعني سيست
ايش؟
مول يعني سيست
مو يعني cyst أيوه.
Okay. Answer.
Always this hydatiform mole occur in reproductive years. There is bimodal incidence. That means higher risk in teens, يعني 18, 19, like this, and also higher in age from 40 to 50, 40 to 50, and 50 kids. The incidence varies according to the community. In the United States, it will occur every 1,000 pregnancy. In Indonesia, 1 in every 100 pregnancy. 1 in 100 pregnancies. That means in Indonesia is a more. Okay? Let us see. This is the uterus, open uterus, and this is abnormal placenta change. This is the mole. Hydatiform. Hydati, that means
Fluid.
fluid. Hydatiform mole, this collection is abnormal of the placenta transforming to hydatiform mole, and here the villi become like a vesicles, grapes, looks like grape. Okay, like grapes, and here look, all of this tissues is cystic. All of this is cyst. you get the growth of the features of
Yes.
hydatiform mold. Let us talk about the pathogenesis. Why is this hydatiform mold? Okay. We said that there is two types of hydatiform mold, either complete or partial. Let us talk about the complete. The complete mold, okay, due to empty ova without any chromosome. That means the maternal side, there is no chromosomal sharing. Either one chromosome fertilize empty ova and undergo chromosomal duplication. It becomes 46 because this 23X duplicate become 46XX. And this we call it homozygous complete mold. Homozygous complete mold. Let us concentrate that there is no sharing of maternal chromosome. Only here there is paternal chromosome. That means this chromosome comes from father, does not come from mother. Okay. Or the second pathogenesis of the complete mold, when two chromosomes fertilize empty ova. Empty ova. But here, either this fertilization come from one sperm and the other sperm, and it's not homozygous. It's a different sperm. Either this sperm carry 26X or 26Y. Also, this may carry 26X or 26Y. This we call it dispermy, and two sperm. Unlike the first one, this is one sperm undergo duplication. So that we call it homozygous. Here, because this two sperm, that means dispermy, fertilize empty ova and may give us 46XX or 46XY.
Where's the Y?
Rare. I know everyone will ask me this question. But very rare, even in the textbook, there is no mention in this 46Y1. No.
النتيجة الأخيرة إما أو ولا دول اللي هذه النتائج.
May reduce 46XX
أو
or reduce 46Y. Okay?
Okay.
If these two sperm have 26X, may develop 46XX. If one or 23X plus 23Y will develop 46XY. At the end, the complete mold have 46 chromosome plus either XX or XY. Okay? This is the first difference between the partial mold. Let us see the partial mold, the pathogenesis of the partial mold. Pathogenesis of partial mold, there is sharing of maternal side. There is 26X from the ova, and two sperm will fertilize this ova. That means will be reduced either 69XX or 69XXY or 69XYY. And this is very rare. And we call it triploid partial mold. Triploid partial mold. This is the first difference between the partial, complete and partial mold. The partial mold is triploid, and this is diploid. And the complete mold either homozygous or heterozygous. Okay? Of the ovary produce ova without chromosome. Without chromosome.
هذا الأبنورمال.
So that we call it empty ova. Empty ova without chromosome. And this is abnormal. So that we produce abnormal abnormal placental tissue. For this reason, there is difference between complete mole and partial mole. The main difference is the number of chromosomes. The second difference, there is sharing in maternal sharing in the partial mole, and this maternal sharing is lost in complete. This is a big difference between partial and complete.
دكتورة
Yes.
فكرة إن تو سبيرم سووا
This is abnormal.
هذه هي الابنورماليتي اللي سوت الديزيز.
Yes. Yes. Normally, you know that when the sperm go inside the ova, they produce enzymes that prevent the other sperm to infertilize. This is abnormal.
الابنورمال هذه هي اللي
So
سوت.
that will produce
High
abnormal placental tissue.
اوكي
ما في هذا أو إنه
فهمت.
You get the pathogenesis?
يس.
Let us talk about the features of complete versus partial hydatiform mole according to the histology, according to the HCG, according to the gross features. Okay? Both of them, gross يا جماعة, both of them will produce vesicles. Will produce placental vesicles. Both of them. But in karyotype, we know that the complete mole, it will paternal chromosome 46XX or 46XY. Okay? Here in partial mole, they are triploid. That means 69XXX or 69XXY or 69XYY, which is very rare. Okay? Here we found that villus edema or villus swelling. Okay? Villus edema in complete mole, all of the villi has hydropic changes or has cystic swelling. Okay? Here in partial mole, we found that some villi has these changes and some are normal. Also, in complete mole, do you suppose that it has fetal part? Which of the mole will have fetal part? Partial or complete?
Both.
Partial.
Both.
This also is a big difference because in a partial there is sharing between maternal and maternal.
اوكي.
Both of them will form fetal part. But in complete mole, there is no fetal part because there is no maternal sharing. Okay? This is also is big difference between complete and partial mole. You get my point? Trophoblastic proliferation. A trophoblastic proliferation this is a histological difference. In complete mole, there is diffuse circumferential trophoblastic proliferation. What does that mean? That means this villi look like a ball and lined from outside with trophoblast. Here we found in the complete mole there is diffuse circumferential trophoblastic proliferation. That means multi-layering. كلها multi-layering. Okay? Here there is a focal or even a slight. يعني some area has this trophoblastic proliferation and some area has not. Okay? Atibia. In complete mole, we found often we present atibia trophoblast. And in the partial mole, absent atibia. There is no atibia. So that complete mole will develop choriocarcinoma. And the partial mole, rare or not. Okay? HCG. Serum HCG and HCG in the tissue. In the serum, we found that in complete mole, it has elevated HCG. In the partial mole, also elevated but less than complete mole.
هل بسبب البروليفريشن؟
Yes. لأنه ال HCG secreted by syncytial trophoblast, inside trophoblast. HCG in the tissue, here also four process. That means the tissue is the mole. And in the partial mole is there but less than in complete mole. And behavior. You know that 2% person from this complete mole may develop choriocarcinoma. Here, rarely develop choriocarcinoma. Let us see, this is the uterus, bisected, and open uterus. This is the ovary, and this is the fallopian tube, and the uterus is filled with this abnormal placental tissue, hydathiform mole, with vesicles, and we see grossly. I saw many of these hydathiform mole in my lab, and I saw vesicles like the grapes, okay? And hydathiform mole marked distension of the uterus, and the uterus become enlarged, so that in ultrasound it become more than that. Okay? You know what meaning of uterus more than that? You know that in the pregnancy there is gestational age. Gestational age, that means this pregnancy is about 9 weeks, 12 weeks, like this. Every week have definite weight or definite size of the uterus. In this condition, hydathiform mole, we found that the uterus is larger than expected date. Okay? يعني if we suppose that in 12 weeks it will be مثلا about 1,000 gram. 1,000 gram.
شلون يقيسونه؟
weight of the uterus.
شلون
Or
يقيسونه؟
size of the uterus. Yeah, by ultrasound.
اوكي.
By ultrasound, you know the size of the uterus, and this is 12 weeks, this is 9 weeks. They determine by ultrasound. But here in hydathiform change, we will find that the uterus become very large to its gestational age. And we suppose that this uterus is 1,000 kilogram, مثلا, in 9 weeks. In hydathiform change, we found this way, yes, 2,000, 3,000 in 9 weeks. So that is larger than its date. Here, let us see histologically the difference between the partial and complete mole. In the partial hydathiform mole, there is a variable villus edema. You see that this is a small villi, and the lining outside is the trophoblast. You see that this is lining by cytoancyl tissue trophoblast. Okay? In partial hydathiform mole, there is a variable villus edema. Variable. Some of which are large, cystic swelling. Some of them are small, like this one. But here, in complete mole, we found that this villus edema all over the villi are enlarged. Okay? And also, let us see here about the trophoblastic proliferation. You see here there is multi-layering of the trophoblast. All of this villi lined by multi-layering of the trophoblast. That means in complete mole there is trophoblastic proliferation very marked. Very marked. Here in partial mole, there is some of them have and some are not. Okay? This is complete mole, complete hydathiform mole, marked villus edema. This is marked villus edema. And when the villi is marked edematous, we call it this cister, like a cyst. Cister. Villus cister. Okay? Let us talk about B57. B57, here in normal, this is a normal chorionic villi. Normal chorionic villi shared chromosome from maternal and paternal. Okay? B53 is a substance that expressed only in a maternal X chromosome. B53 have from father and from the mother, but the gene from the father does not express, does not appear. So that here, in normal chorionic villi, B53 it will be positive because it will be expressed by maternal. Okay? But here, incomplete mole, there is no. There is no B53. Because the gene is there, but they are not transcribed. So that when we thinking about is it mole partial or complete, I will do B57. If it is positive, that means it is partial. If it is negative, that means it is complete. Why? Because the complete will come only from maternal, from the father. Okay? An empty ovum. So that here, this is a positive B57, okay? Both in the villi and in the stroma. But here, in the complete mole, B57 is lost because it was not transcribed.
سارة يعني يطلع بالنورمال
بالبارشل.
Yes.
Again,
no, في النورمال الchorionic villi has no trophoblastic proliferation, has no cystic swelling. The changes that occur in the hydatiform mode will not be found in normal placenta. But when I said before, the abnormal placenta or hydatiform mode, firstly you see the vesicles. In the normal placenta there is no vesicles. Even when doing histopathology and seeing under microscope, you do not find the trophoblast proliferation. You do not find proliferation of trophoblast. So that when I received a tissue with vesicles, and there is no fetal part, and there is no other evidence that this partial or complete, at this point I will do B57. If it will be positive, that means this is a partial. It will be negative, that means this is a complete. You get my point, all of you? Munira, you get my point? شكلك نايمة يا منيرة. Invasive hydatiform mole. This is the second tumor. Definition: invasion of uterine wall by molar villi. It is a molar villi. It is a molar villi. All the features that mentioned in the hydatiform it will be here. Okay? But the difference between hydatiform mole and invasive mole, this is the penetration of myometrium. Okay? And can embolize to the distant site. Even can go through the blood into the lung and brain. But it does not produce plastatic foci because it was not capable for independent birth, not like malignant tissues. It is biologically benign. It is a benign lesion. It is not malignant, but it has the ability to invade. Clinically, the patient came from complaining of vaginal bleeding with variable uterine enlargement. What is the meaning of variable uterine enlargement? Yes? Yes.
But can you
That
bulge?
means where this mole infiltrates the myometrium, it becomes enlarged. And where there is no invasion, it will become normal. So that there is a variable uterine enlargement. At area there is invasion, it will be enlarged. At area it will not invade, it will be normal. Okay, so that this is a variable uterine enlargement. Consistently high HCG level. All of this condition have high HCG level. It regrets and responds to chemotherapy. It is benign, but for this invasion phenomena, in this condition, it will be given chemotherapy. And after the lecture, and you go and take a sleep, and you think at the night, why they give them chemotherapy and it is a benign?
Yeah,
And all of you will ask me in WhatsApp like this question. From the start, it is a benign, but it has the ability to invade. To stop this invasion, I will give them chemotherapy. Chemotherapy is not given only for malignancy. It will be have autoimmune diseases. Okay? And this condition, this is a biologically benign, but it has ability to invasion, so that I will give them chemotherapy, I will give them methotrexate in name, and it responds very well. Okay? And also we need follow-up to avoid formation of choreography.
بس النقطة الثالثة وش معنى إنه don't produce metastatic foci capable of independent growth؟
Here, you know that in malignancy, the malignant tissue has the ability to form new vascularization. And the malignant cells has the ability to produce some substance like hyaluronidase, enzymes that have ability to take even the cytokines from the tissue to grow, and even has ability to form a new blood vessel to supply this new tissue by the blood to survive. Here in this condition, this metastatic emboli have no this ability, so that they will go to the lung and brain, but
No
will
growth.
not survive because it has no ability to survive there, because they have no ability to form a new blood vessels. And you know that if there is no blood supply, that means the tissue will be died. Okay? Here, this is a growth of the invasive mole. This is the tissue of invasive mole, and this is the tissue of invasive mole invading into myometrium. Okay? Let us talk about gestational choriocarcinoma. Gestational choriocarcinoma. By definition, it is a malignant neoplasm of trophoblastic cells derived from previous normal and abnormal pregnancy. And even this choriocarcinoma can develop in normal pregnancy from the placental tissue. Okay? Or abnormal pregnancy like complete hydatiform mole, even invasive mole may progress or transform to choriocarcinoma.
Complete breast.
So that is gestational choriocarcinoma may arise from normal and abnormal pregnancy. From which? From the placental tissue, because it is a malignancy of the trophoblastic cells. Okay? It is very aggressive tumor, invades the blood vessels early in the stage, and widely metastasized, but fortunately it responds well to chemotherapy. Okay? One of 25,000 pregnancies in the United States may develop this choriocarcinoma, and one in 2,500 in Nigeria. That means it is more common in Nigeria than in the United States. That means it is more common in Africa. Okay, places. What is the precursor of this choriocarcinoma? It arises, 50% of this choriocarcinoma arises from hydatiform mole. 25% of the choriocarcinoma arises from the previous abortion.
بقايا البيبي.
Yes, بقايا البلاسنتا. بقايا البلاسنتا. 23 of normal pregnancy. 23 of this choriocarcinoma arise from normal pregnancy. 2% from ectopic pregnancy. It is a malignancy of the placenta. It is a malignancy of the placenta. Either this placenta, it was hydatiform mole, which occurred in 50% of the choriocarcinoma arise from this hydatiform mole. 25% of this choriocarcinoma arise from the previous abortion. 23 from normal pregnancy. 3% of ectopic pregnancy. Okay? So that don't leave the remnant of the placenta inside the uterus. You have to evacuate all the remnant of the placenta. So that after delivery, every midwife be sure that there is no remnant of the placenta to avoid this occurrence. May occur or may not, but you have to evacuate all of the tissue. Even in abortion. This is his uterus, open uterus, with ovary and fallopian tube and intrauterine tumor, and this is choriocarcinoma. Choriocarcinoma invading the myometrium. Here, it invades the myometrium and even reach up to serosal surface, up to parametrium outside. Okay? And it is hemorrhagic and necrotic tumor. Okay? Hemorrhagic and necrotic. Let us see. This is a choriocarcinoma, malignant, cyto, and syncytial trophoblast. Malignancy, cyto, and syncytial. Both of them are malignant. Okay? The main characteristic of this choriocarcinoma, it will never ever forming the line. If you found the line, that means it's not choriocarcinoma.
وش الفيلاي طيب؟ يعني في كور
chorionic
الفيلاي
villi.
يسوي فوق.
chorionic villi.
في كور بالوسط حق البيبي
What?
كابيلاريز حق البيبي يكون بالوسط بين التروفوبلاست
No. You know that the placenta is formed from villi. This villi is a structure. There is edematous or mucinous stroma in the center, and the outside this villi is lined by cyto and syncytial trophoblast. This is a normal. But here, in malignant transformation, when it becomes choriocarcinoma, the structure villi is not present. Only malignant syncytial and cytotrophoblast. Okay? So that when we found villi in the tissue, that means this is the other diagnosis. It is not choriocarcinoma. Because choriocarcinoma, it will never ever form in villi. Only malignant cyto and syncytial trophoblast. Okay? Invading myometrium, upper right, in upper right, here, the upper right, this one. This is thick-walled blood vessels. And these thick-walled blood vessels found in myometrium. Okay? And here there is a bundle of smooth muscle. And this is the tumor, choriocarcinoma, invading the myometrium. Okay? In this one. In the upper left, this one, this is the malignant cyto and syncytial trophoblast. This is cyto or syncytial? Syncytial. This is the malignant syncytial trophoblast. And this is malignant cytoplasm. A mononuclear cyto with multinucleated syncytial. And both of them are malignant in the hyperchromatic nuclei. كل features of malignancy. INC ratio, polymorphism, mitosis, all of this. Okay? Syncytial trophoblastic cells surrounding the cytoplasm. Here, this is, you know that the syncytial trophoblast have a syncytial growth. There is no cytoplasmic borders, cytoplasmic membrane borders. All of the nuclei inside one cytoplasm. This is the syncytial trophoblast. Here, this is the malignant cells, malignant syncytial trophoblast surrounding malignant cytoplasm. This is the cytoplasm, this is the cytoplasm, and this is syncytial trophoblast surrounding it. Okay? Both of them are malignant.
بالأبر ليفت دكتورة وش المميز
The
ده؟
upper left, this is the hemorrhagic tissue. You know that this is the hemorrhage. Okay? And this is the malignant syncytial trophoblast, and this is a scattered malignant cytoplasm. Okay? And it is aggressive tumor, always forming hemorrhage and necrosis. Okay? And has the ability to metastasize hematogenously earlier in their stage. A clinical feature of gestational choriocarcinoma manifest as irregular, the patient came complaining of irregular vaginal spotting or the bloody brown fluid, and this discharge may appear in the course of apparently normal pregnancy. And a lady came to you, normal pregnancy, complaining of this bloody discharge or brown fluid come out, and after that you get ultrasound and find this choriocarcinoma. And also the lady may came with same clinical feature after miscarriage, abortion. After curettage. Okay, may develop bone may disclose the presence of metastatic lesions. At the time of the diagnosis, if you do just X-ray or X-ray for bone, you found this metastatic lesion. So that this tumor has propensity for hematogenous spread earlier in the stage. At the time of the diagnosis, the HCG levels are typically elevated to level above those encountered in partial, in complete and partial. Widespread metastases are characteristic. Widespread metastases are characteristic for choriocarcinoma. The most common site for this is the one, 50%, vagina, 30 to 40%, and followed by brain, liver, bone, and kidney in descending order of frequency. Despite this characteristic, or despite widespread metastasis, even after metastasis, it responds well to chemotherapy. Even with lung metastasis, brain metastasis, unlike the other solid tumors or solid malignant tumors. This choriocarcinoma, it is spread earlier and it has wide spread metastasis, but it responds very well to chemotherapy. So that if we face any lady with this choriocarcinoma, reassure her this is a tumor responds well for chemotherapy.
Good prognosis.
With good prognosis. Let us talk about the last lesion or last tumor. It is a placental site trophoblastic tumor. Placental site trophoblastic tumor. This tumor arrives at the site called the placenta. It arises from cell called intermediate trophoblast. Extra villus intermediate trophoblast. These cells found in between the villi. It is not like cytosensation trophoblast surrounding the villi or covering the villi from outside. It found in between the villi. We call it intermediate trophoblast. And it secretes human placental lactogen. Those sensation cytotrophoblast secrete HCG. This cell produces human placental lactogen.
لا مو بنفسه.
No, different human placental lactogen and HCG. Intermediate trophoblast, normal extravillous trophoblast are polygonal mononuclear cells that have abundant cytoplasm and produce what we call human placental lactogen. The mass of this tumor infiltrate into myometrium. And can follow also normal pregnancy, spontaneous abortion, or molar pregnancy. It has also moderately elevated HCG, moderately. The higher one is the choriocarcinoma. After that,
الهيدرونيفرس
complete hydathiform mole, invasive mole, and here also placental cytoplastic tumor. That means these tumors, there is two tumor markers, human placental lactogen and
Normal.
Both of them are elevated in this tumor. And prognosis is excellent if it is localized disease, it is not metastasizing, or also the prognosis is excellent if the duration is less than 2 years interval between the diagnosis and the previous pregnancy. Okay? This is the placental site of a plastic tumor. As we see here, this is uterus, and this is the tumor. And here this is intermediate trophoblast with malignant features, pleomorphism, hyperchromasia, and may form multinucleated cells.